on?
Yes, please.
All right. So so there's a little diagram to illustrate what we've just talked about concerning the eyelid. So we have an anterior layer or an anterior lamella, and then we have a posterior lamella, and this is the eyeball itself, the cornea to be exact. And then we have the tarsus here, okay, which is separating the what do you call it? Okay, so the tarsus here marks the beginning of the posterior what do you call it? The posterior lamella. Okay, and we've said that the retractor muscles are attached to the tarsus. Okay. All right. Okay, so we can see here our orbicularis muscle, as we mentioned. Okay. You have the slides, so when you get them, you can look at them into further detail. Okay, so each eyelid has all of these structures in varying combinations. What that means is that for every individual, the quantities or the levels at which you'll be seeing these structures or their insertions might be different. So talking about the skin, the Glarus, Levator, poneurosis, Muller's muscle, tarsal plate, orbital septum, and the palpebral conjunctiva. So look at it. Okay, so then again, so when we go to the conjunctiva, we'll look at it into more detail, but then the mucous membrane that is lining the inner surface of the eyelid and folding onto the eyeball itself is what you term the conjunctiva. But we'll look at that in more detail. As I said, for every aspect that we will be delving in, we'll do a review of the relevant anatomy again before we continue. So no need to worry, all right? Okay, now, there's a muscle we call the levator palpebrae superioris, all right? And this is the major muscle that helps the upper eyelid to move, to open and close. And it's said to originate from the annulus zini, and it's innervated in the inner posterior 1/3 by the superior division of the third nerve after it passes through the superior rectus. And it extends anteriorly about 40 millimeters and becomes tendinous at the Whitnall's ligament. So the tendon of this levator palpebrae superioris fans out and fuses with the orbital septum and sends strands to the skin and inserts into the anterior lower tarsus. So basically, the take-home message is that the levator palpebrae superioris is the main muscle that helps the upper eyelid to lift and close. Okay. All right. So this is a diagram that is showing how the various muscles in the eyelid are arranged. All right. So we have the orbicularis oris. Okay. So it's more of a circular muscle here. All right. Okay. So the orbicularis muscle. So this is a subcutaneous muscle that acts as a sphincter of the eyelids. The orbital, preseptal, and pretarsal sections of it. And then a small strip of it is the pretarsal orbicularis at the lid margin, which is called the Rowland's muscle. We can skip that. So the orbital septum, earlier on I mentioned that the orbital septum sort of separates the anterior, anterior lamella from the posterior lamella. So it forms the anterior border of the orbit and helps to confine the fat inside. It is posterior to the orbicularis muscle formed at the rims as the arcus marginalis. And it inserts medially at the posterior lacrimal crest and laterally anterior to Whitnall's tubercle, and it fuses with the levator superioris at a variable height. So it varies for most people. Now, another very important part is that the blood supply to the eyelids. So they have a very rich blood supply from various sources. In particular, what's interesting to note is that each eyelid has a medial blood supply and a lateral blood supply. And the supply to it is via the ophthalmic and the lacrimal plexus of vessels. And they've come in through the facial system. That is, they follow the pathway of the facial nerve. All right. So the ophthalmic artery, I'm sure you've done CNS, so you remember the ophthalmic artery. So the ophthalmic artery is the first intracranial branch of the internal carotid. That means that when the carotids move into the neck area, the first branch they give when they get into the cranium is the ophthalmic artery. And this artery enters the orbit with its surrounding sympathetic fibers through the optic foramen. I mentioned that there are two main apertures in the orbital apex. One is the optic foramen and the superior orbital fascia. All right. So it enters with the surrounding sympathetic fibers through the optic foramen lying beneath the optic nerve, All right. Now, the central retinal artery is its first branch, and it perforates the nerve at about 8 to 15 millimeters from the globe. All right, so the ophthalmic artery's main branch is what we call the central retinal artery that supplies immediately from behind the globe. Okay, so now we proceed to the lymphatic drainage of the eyes. Now, this is important in that I'm sure, as you might have realized by now, for every condition, most conditions, whether neoplasms or whether infections, you would want to, knowledge of the lymph drainage can give you a fair idea of where there's metastasis or where the infection is coming from. And so for the eye, the lymph nodes that it drains to are the preauricular node. The preauricular node is just in front of the ear, and the submandibular node. The submandibular node is just beneath the angle of the jaw. So these are the two main lymph nodes that the eye drains to. All right, so nerve supply of the eye. Now, we all know the trigeminal nerve, that is cranial nerve. It splits into three branches. We have V1, V2, and V3. V1 is the ophthalmic nerve, V2 is the maxillary nerve, and V3 is the mandibular branch. So V1, which is the ophthalmic branch of the trigeminal, it provides sensory branches to the ciliary ganglion, which is lateral to the optic nerve. And the terminal branches form the nasociliary nerve, which also forms which also gives branches to form the infratrochlear nerve, and that supplies the tip of the nose. So in certain injuries that affect the orbit, when this nerve is affected, one of the things that we look out for is to test for sensation at the tip of the nose. And that will let us know the extent of the injury and how the ophthalmic nerve might be involved. Okay, so this is another schema of the nerve supply, but you don't need to know all of this, all right? Okay. Now, if you're looking at the orbit, the anterior aspects of the orbit, there are a number of nerves that give sensory innervation to the eyelids. Okay, quite a number of them. You can say about 6 or 7 or so. We have the lacrimal nerve, we have the zygomaticotemporal nerve, we have the zygomaticofacial, we have the infraorbital, infratrochlear, supratrochlear, and supraorbital. So all of these are responsible for the sensory innervation. That is, the ability to feel touch on the eyelids is due to the presence of these nerves listed here. Okay, so this is just a schema that shows how the innervation goes in through the eyelids, but that is not very important for our discussion this afternoon. I think I've mentioned this already. Okay, so this is just a bigger diagram that shows the various parts of the head and where their sensory innervation comes from. You don't need to know all of this. Maybe a few for the eye, it's okay. Smallest muscle, we can skip that. All right, so now let's move on to the lacrimal production. So we all know that one interesting thing about the eye is its ability to produce tears. And this, I believe, or I think, is very important to our ladies especially. You know, they need the lacrimal function of the eye so that they can cry well. All right, so just something little on the lacrimal production. So the tears that are produced from our eyes are largely from two main accessory glands. One, the Krauss and the Wolfram glands. Okay, so they produce the basic lacrimal secretions that moisten the eye, while the other large gland in there is more for reflex. So maybe when something falls on the eye, for instance, that's you know, sudden onset of the tearing that comes upon the eye is more from reflex secretion. We also have goblet cells. I'm sure by now you all know that goblet cells usually just produce mucin or mucus. Okay, so we have some goblet cells in the conjunctiva that produce mucin. And the mucin and the tears come together to form the film that keeps the eyeball moist. Okay, now we also have meibomian glands and also plus structures there, which are all helping to produce the mucus and the tears that we need for our eyes. Okay, the details of the mechanism by which they produce these structures are not important for our discussion. Okay, so this is just a diagram showing the lacrimal or the tear secretion apparatus that I've mentioned. Okay, so we have the gland of Krauss here, we have our gland of Wolfram here, and then also this is the orbital or the orbital aspect of the lacrimal gland. Okay, all right. So these scripts here just produce mucin. Okay. All right. Yes, so there's another diagram trying to explain the anatomy of the drainage. Now, as we've already described, the Wolfram and the Krauss will produce the tears. And when they come onto the eye, okay, they are drained .
Hello, Doc. Please, we can hear you.
I'm back. Okay, can we go on?
Yes, Doc.
All right, so we continue. I had a small technical challenge. You know, Ghana, everything technical hitches here and there. It's normal.
That's all right.
So did you hear what I said about this diagram?
We
Or
missed
it was
that
off?
part. Yes, please.
Okay, so I was saying that the tears are produced from the lacrimal glands here by movement of the eyelids. They line this place, they line the eyeball or the globe, and then
No,
they
please,
are
we are not seeing
drained.
your diagram.
The slide, we can see the slide.
Oh, sorry, I didn't share the slide. Sorry. Okay. All right. Okay, sorry about that. Yes. So you can see now.
Yes, Doc.
Yes. So as I was saying, the tears we produce from here, they will come and line up on the eyeball. Then it will drain through the caruncle, which is at the medial aspect. If you look into your friend's eye very closely, you see that there's a small hole, a very small dot at the medial canthus, which we call the caruncle. So the tears will drain from there and enter into the lacrimal duct and come into your nose. That is why when you cry, then you start blowing your nose. It's just the tears that run through the lacrimal duct and into your nostril. So very soon you cry and you start, you know, so that's where that comes from. So I could ask you to explain why Auntie Sabia went to her mother's funeral and started crying and shortly started blowing her nose. You should be able to explain the mechanism, isn't it? Simple. So anyway, so it's good to come for class. One by class, exams questions, I want to back or they say the exams is hard. Meanwhile, you know it's cool. Anyway, that was just by the way. So this is just emphasis what I've already explained. So tears are produced by the accessory and main lacrimal glands. And the distribution of these tears over the surface of the eye is achieved by movement of the eyelids that spread the marginal tear film. And the passage of the tears into the nose occurs via the lacrimal drainage system. And that is what I've said leads to you having a runny nose when you are crying, all right? Okay. Yes, so the next aspect we want to look at are the extraocular muscles. We will have, there's a topic on squint or strabismus, so we won't spend too much time on that. Just for you to, I mean, since we are doing anatomy, yeah, going through it, but we'll go into further detail later. So we can see the, we have our inferior orbital fissure, we have the superior orbital fissure, we have the optic canal here. And most of these muscles, extraocular muscles, are coming out from here. They are said to be extraocular muscles because there are muscles inside the eyeball, but these ones are muscles on the external, that is outside the eyeball. That's why they are called extraocular muscles. So we can see here we have our superior rectus, we have our superior oblique and all of that. So we'll go into detail. So let's skip that because of time. Yes, so these are the eyeballs and how they are attached. I promise we'll look at it in the detail later. Okay, now there's something we call spiral of tilo. It's a favorite exam question, so I'll just say it. So this spiral just looks at the insertions of the extraocular muscles on the globe or on the eyeball. All right, and each of these muscles, or the extraocular muscles, is about 40 millimeters long, and they all insert anterior to the equator or over the ora serrata. Now, the spiral of tilo is coming in, and based on, if you are trying to, let's look at this diagram. If you are trying to, where's my pointer? I hope you can see my pointer.
Yes, please.
Can you see my pointer? Yeah. Good. So now these are the various aspects where all of these muscles are attached, okay? Now, the spiral of tilo is basically just describing the circle that the attachments are forming. So you can see that they are attached here, and I'm drawing a line all around the insertion. You get me? Can you all see? So this is the spiral of tilo, okay? Now, there's something interesting about the spiral of tilo in terms of where the muscles are inserted. That's basically why there's something called spiral of tilo anyway. Hey, you know, sometimes I say people who invented these things, they were students, so all kinds of things. You have to learn all kinds of things. Anyway, but this is important for the ophthalmologists when they have to operate on the eye, or they have to operate on things like strabismus or squint. The spiral of tilo helps them to know approximately where they will find each of the muscles attached, so that if they need to adjust them or need to dissect them or something, they would know exactly where to find them. Okay. Now, the limbus. Okay, so I was going to talk about the limbus when we get to the conjunctiva, but it seems it has come up, so we'll just talk about it. Now, the limbus is where the cornea meets the sclera. We'll look at that shortly. So, can you all see this one here? So this is our limbus. This will be our limbus because the cornea is meeting the sclera. Okay, so we are using the distance from the limbus, okay, to measure. So this is, if we want to look at the distance of the medial rectus to the limbus, we'd measure it here. If we want to know the distance from the limbus here to the lateral rectus, we'd measure it here. Okay, so now that brings us to the point that we're saying. Now we're saying that this distance from the limbus to the insertion increases from the medial rectus to the internal rectus, to the lateral rectus, the superior rectus. What this means is that the medial rectus has the shortest distance to the limbus, followed by the internal rectus, followed by the lateral rectus, followed by the superior rectus. So a favorite exam question is that I could ask you, what is the circle or the spiral of tilo? So that will be A. Then B, I would ask you, what is the clinical relevance of the knowledge of the spiral of tilo, right? And then I could ask you to arrange, or describe the circle into further detail. If it's multiple choice questions, I could twist this, of course, by saying that the limbus insertion decreases from medial rectus to internal rectus,
Doc, please, you have muted yourself.
Yes, sorry about that. I needed to do something. Okay. All right, so continue. So I hope it's clear about the spiral of tilo, isn't it?
Yes,
okay,
sir.
so this is another diagram. Yes, can you hear me? Okay, so there's another diagram that is showing the attachments of the various muscles. Like I said, we'll discuss it in detail, so let's skip for now, okay? So same thing, it will come. The various muscles and how they are attached and what they do, that will also come. So let's leave that for now. Okay, what is this? So the muscles and their actions, we'll come to that when we are looking at strabismus, okay? So we'll skip this one too. No cause for alarm. All right, so let's move on quickly to the anatomy of the front view of the eye. So I think we've talked much about this, but just to put everything in perspective. So I've said that the eyelids, their main function is that they protect the eye and they also lubricate the eye, okay? And this is what I've said. So this is the medial canthus, this is the lateral canthus. And the caruncle would be somewhere here. I hope you can all see my cursor, my pointer rather. So the caruncle is somewhere here. This is the medial canthus, this is the lateral canthus, okay? And the caruncle here contains the puncta, okay? And that is where the tears are drained from, all right? And this is a lateral or coronal section of the eyeball. So you can see the internal structures. Okay. Then the conjunctiva. So the conjunctiva is a whole lecture on its own, but I'll just talk about it briefly. It's a transparent mucous membrane that lines the anterior aspects of the eyeball as well as the inner aspects of the eyelids. We'll look at them into details, all right? And interestingly, your job as physician assistants much of the eye complaints or most of the eye complaints that you're going to be seeing will be problems related to the conjunctiva. That is why it's a whole lecture on its own, okay? All right. So the other aspect of the eye is the sclera. The sclera is the white part of the eye, And the transparent part of the eye through which we see all the other aspects of the eye is termed the cornea, okay? So the cornea, so with this diagram here, the cornea is all of this aspect here. This all of it. The inner one here is the iris or the pupil, okay? The pupil is the space or the cavity or the aperture in the iris, okay? So this whole white part is the sclera. This whole black part here is transparent, that is the cornea. So you're saying that the cornea is an avascular clear window, and it is responsible for 2/3 of the refractive power of the eye. So even though the lens helps us to focus, the lens doesn't carry most of the refractive power. It is the cornea, okay? So watch out for this in multiple choice questions. I can easily twist this one. And I don't know why, I'll say this, but the people don't come for lectures. They will always choose the wrong one, even though I've said it. Anyway, all right. So there are a number of conditions that can affect the cornea and cause it to become opaque, which will make vision almost impossible. We'll talk about that into details. And as I said, the iris. So this whole iris here. So every human being, your eye color is given by the iris. I hope you can all see the iris here. Iris, iris, iris. So this person's iris is giving you more of a gray ash color thereabout, but this is an effect I will look at shortly. Okay, so the iris, like I said, the iris is the whole of this ash structure that we can see here. The whole inside, the black hole inside, is the pupil. Be mindful of twists and turns in multiple choice questions, right? And so it's basically the iris basically contracts or relaxes to increase the size of the pupil. When we get to accommodation and refraction, we'll go into more detail on that. Okay, all right. Well, basically what you need to know about the iris is that it's made up of two main types of muscles. It has radial muscles. I don't know if you can see the radial muscles or the radial structures running here, as well as this side. Okay, so the radial ones are responsible for causing the pupil to become enlarged. And the circular muscles, when they contract, then the pupil becomes smaller. Okay, so that is it. So the pupil, as I said, is the central part of the iris, okay? And that is where you'd see through into the lens. Now this one here, this pupil is white because of the presence of cataract. Cataract is also a lecture on its own. We'll look at that also shortly, as well as glaucoma. Now, there's a lateral section of the eye. This is the whole of the eyeball, as you can all see here. And this is the, this one here is the cornea. This part is the transparent part. So when you look through, you'd see the iris. I hope my cursor is still visible. So this is the iris here. This is a cross section of it. So it looks like there's an up and a down thing, but rather it's a circular structure that we are looking at on the side. So the space through which, the space between or inside the iris is the pupil. So this is the pupil here. And through the pupil, we see the lens. So this is the lens here. We can all see my lens. Yes. All right. Okay, so then the lens is attached, or the ciliary body is a structure. Okay, it's not very present on this picture. I'm sure we'll get another picture that will show that. We have our ciliary body here, which holds onto the suspensory ligaments that attach to the lens. We'll look at the anatomy of the lens into detail later when we are dealing with cataract. So not too much detail for now. The inner layer of the eye, which is the retina, is shown here. Okay, and then so it has an outer coat. Okay, you can be asked to describe the eye, the various layers of the eye. So it has an outer coat, and then has a medial coat and an inner coat. Okay, So the remaining 1/3 refractive power of the eye is given by the lens. So even though the lens is what helps us to see, it gives us only 1/3 of the refractive power, but the importance will come when we are looking at cataract. Okay. So now the ciliary body, which I said, so this is the ciliary body. It's attached to parts of the iris and also gives us suspensory ligaments onto the cornea, onto the lens. Okay, and it's responsible for producing the aqueous humor, and also helps us accommodate, because as I said, it is attached to the iris here, but it has suspensory ligaments that hold on to the lens. So when it contracts, it flattens the lens. We'll look at it into detail. Yes, so the zonules are the structures that attach the lens to the ciliary body. That's the zonules. Okay. So this is a partially dislocated lens, which is making the zonules more visible. And then the red reflex. When you look into the back of the eye, you'd see the red color, which we refer to as the red reflex. Sometimes when you take pictures in the night, you realize that the people's eyes are red. That is the red reflex that is seen there. It's very important for eye examinations, as we shall see shortly, later. And then the fundus. When we're doing glaucoma also, we'll talk about it more. There's something we call the cap to disc ratio that helps us to determine how much damage is occurring in the eye. And this is what I've already said. There are 3 coats of the eye. We have the outermost layer, which is fibrous, and it's made up of mainly the cornea and the sclera. The middle layer, which is the pigmented aspect, is made up of the vascular aspect with the uvea, the iris, choroid body, and and then the inner layer is the retina, which is also shown here. Okay. Oh boy. So this is all that I've said, being shown in more detail. Okay, so I think we'll end it here. So that brings us to the end of this lecture. And what again? I don't think we have much questions. Okay, if there are any questions, we'll take about 1 or 2 questions for the next 3 minutes, and then we can call it, can wrap it up. So the floor is open for questions.
Doc, we have less than 2 minutes, so maybe we can use that.
Yes, so at the end of it, we are closed. But just for you to know, we have our next lecture is when? Thomas, can you remind us? I forgot. Was it Monday?
Doc, you said we're going to do Saturday, Sunday, Mondays, Wednesdays.
No, our next lecture. When? The exact next lecture. Is it Monday? I think it's Monday. Okay. First, no, Mondays. It's not Monday. It's rather Tuesday. Tuesday morning. You said in the morning is not appropriate.
No, sir. Morning will not be possible.
Tuesday afternoon.
We could do after work.
All right. So let's be looking at it, and then also Wednesday again, and then Friday again, and then Saturday, and then Sunday. All right. So questions, quickly. I'll send the slides to your class rep so that you can share to them.
All right.
Yes, nobody's talking. So today there were only 57 of you. The remaining 30 were absent. Are we done?
Yes, Doc.
Okay, so there are no questions then.
I guess
okay.
So.
All right then. Then have a nice day.
You too.